welcome to this episode of Thrive Talks To. I'm Sourovi Day, Education Practice Lead at Oxford Policy Management. Thrive is an early childhood development research program focused on 5 countries: Bangladesh, Ghana, Kiribati, Sierra Leone, and Tanzania. Thrive aims to support these countries to turn what we know about early childhood development into practical, scalable, cost effective programs that can improve childhood health, nutrition, education, and well being, potentially transforming societies across generations. In this episode, I'll be talking to Professor Susan Walker, a Thrive research director. Susan is a global leader in the research, implementation, and scale up of early childhood programs to improve children's health, cognition, and overall development in low and middle income countries. She's professor of nutrition at the University of the West Indies and was the director of the Caribbean Institute for Health Research at the university between 2012 and 2020. I'll be asking Susan how successful early childhood development pilots can be effectively scaled up within the same country or when adapted to other countries, based on her experience with the internationally known Reach Up Early Childhood Development Program. Susan leads the research team on the Reach Up program in Jamaica. Starting as a research pilot, ReachUp has been rigorously evaluated and adapted for delivery in 18 countries, including Brazil, China, India, Kenya, and Zimbabwe. It has also been adapted as a national program in Bangladesh, Jamaica, and Peru. I'll be talking to Susan about the success of the program and its scale up, the challenges in scaling and adapting the program, and what researchers and practitioners should bear in mind when considering successful pilots for scale up. Welcome, Susan.
Thanks, Sourovi.
So let me start by asking, what is the Reach Up program and what has made it so popular and successful in Jamaica and other countries?
The Reach Up program really started life as the Jamaica Home Visiting Program. And that was a program developed by Sally McGregor in the 1970s and 1980s in Jamaica, when she was working primarily with undernourished children and had seen the big gap in development between children who'd experienced undernutrition, as well as the gap for those children who were socioeconomically advantaged when compared with more affluent Jamaican children. So she thought that it should be possible to help their parents to better support their development through play. And so she developed the Jamaica Home Visit curriculum and with a focus on reaching families with children disadvantaged families with children 0 to 4 years old. The program was designed to try and be feasible from the start so that it could be delivered by persons from the community with at least a minimum of complete primary education. And then it was important to have good training of the visitors so that they understood the key methods of the program, which were centered around an emphasis on quality relationships with the parent, usually the mother, how to introduce the activities, the demonstration and discussion with the mother about the activities that were being introduced at that visit, and making sure that the mothers understood, but also a lot of emphasis on encouraging the mothers and in praising the child and the mother when they made an attempt and were successful, even if they were not successful, but that they were engaging and trying. Because part of what we also wanted to do was not just to improve the child's development, but improve the caregiver's enjoyment and also her self-esteem as a parent. One of the things that was also done, and right from the beginning, was to conduct rigorous evaluation of how it was working. That evaluation has been very important for that program and Reach Up going forward, because evidence has been a very critical thing for policymakers. Reach Up began in around 2013, 2014, when we were getting a lot of requests from countries to implement the program. And so we developed a comprehensive package which provides the resources, the curriculum, which goes now from 0 to 4, training manual, training films, guidance on how to supervise and maintain quality, guidance on how to adapt the program for context, as well as obviously a toy manual, since it's a very play-based intervention. Very importantly, they can change it to work with the system that they have in their country, in terms of how they're going to deliver and who's going to deliver, which sector is going to deliver, because it's often health, but doesn't have to be health. So those are some of the advantages of the program. Probably one of the reasons it is so popular.
Thanks a lot, Susan. So, one of the really remarkable things about the Reach Up program in Jamaica was how those early childhood gains lasted well into later life. So, based on the research that you and colleagues did on the program at the pilot level, what impact did it have on children, mothers, and families receiving these home visits?
In 1985, the curriculum had been evaluated in some small, very small studies, and the group started a new efficacy trial which focused on stunted children. The reason for this is that stunted children, it had been shown to be a really high risk, were at high risk for poor development. We did a neighborhood survey of poor areas in Kingston and enrolled children into the trial, when there was a randomized control trial. What we showed at the time was, after 2 years of intervention, there was a very large impact on children's development, as well as significant impact on their home environments. It meant we had been changing some of the parenting behaviors and practices. What's been so impactful from this study is that we were able to then follow the children forward through childhood, adolescence, and now twice as adults. So, and I don't think at the time, when we finished the trial, we ever really imagined we would do this. But it's really made the study unique in the literature. And what we found is that benefits emerged over time. At an early age, when children are learning foundational skills, maybe the benefits of the early intervention aren't so obvious. But as they get older and they're now performing more complex skills, then we really began to see the differences. So that differences in IQ were evident at age 11. They continued in late adolescence, when we also saw benefits for behavior, benefits for mental health, benefits for educational achievement. And now in adulthood, we've also reported benefits for income, so that the children who had participated in it are actually earning more than those who hadn't. So the impacts have really been life-changing for some of the children. And so we need to be cautious, I think, around those early years, and thinking, well, we haven't seen a big impact at age 6, and that's it. So everything's gone. It actually seems that the benefits may emerge later on in life.
Great, thank you. You and the team took Reach Up from a small research pilot to a scaled up program that governments can deliver effectively at the national level. How was that transition from a successful pilot to a national program?
So if I talk about the what has happened with us in Jamaica, taking the pilot from Jamaica through to scaling, the first thing is it's really still a process. It's not something completed. We haven't reached full national scale yet. So the process began with continued stakeholder engagement, and was helped by the increasing evidence base and international recognition of the work. And I would just say that I think that phase of the process might be quicker now because the global context in the 1980s, early 1990s is very different from the global ECD context. Very different now, with many governments much further along in their awareness, at least, of the need to do something in ECD, though they may not actually be doing anything yet. But in Jamaica, what eventually happened is that the evidence book got through, and we were approached by the Ministry of Health and Wellness here to help them implement their early stimulation program. We started working with them in 2018, and first in training staff and in the program, and then they agreed with us to do a smaller initial phase during which we could do evaluation. So the initial phase began in 2019 and was across the whole country, but in selected health districts. So not every health district received the program at this stage. So it's national in that the scope is across the country, but it's not national in that some health districts are providing the program and some aren't. Unfortunately, the program was just getting off the ground when COVID came. So that put an end to home visiting for a long period. It did, however, give us the opportunity to develop some remote methodologies and to test those methodologies. So there was a little bit of a gain, but we were really disappointed because the program was going well and we were on track to evaluate it. We have just earlier this year finished second attempt at the trial, and have shown that as delivered by the ministry, by their staff, with their staff supervising, with them providing almost all of the resources for the program, that we have modest benefits for the children's development and for parenting behaviors. So that's really a big deal that even with all the challenges, and there were many in addition to COVID, so we're happy we had an impact, but there were many challenges, and we really want to begin to examine how the different issues affected outcomes. So, for example, many of the community health workers who delivered the program had the full training in Reach Up, but they had that in 2019. There had been new hires, and they got a much briefer training. And so it gives us an opportunity to look at training as one of the aspects that might affect outcomes. We also had lots of variability in how well the supervision was done across the different health districts and health centers. And we can also look at, the extent to which other duties and responsibilities that the community health workers had, how did that affect their ability to deliver the program? We have shown that the ministry can deliver the program. But so we've also identified many challenges in implementation. So what the next steps are here is that we would discuss with the Ministry of Health how we can adjust, where the program can make adjustments and what's possible to improve implementation before moving on to expand to other health districts when they have the resources to do that.
Thanks a lot, Susan. So that was Jamaica, but what impact has Reach Up had when implemented in other countries? Have the positive effects on children been seen across contexts and countries?
In most of the countries where we've partnered with country teams to deliver the program, there have been positive benefits for children's development and when it's been measured also for parenting practices. Last year, in 2023, we were able to publish a meta-analysis of 18 trials that had been completed at that time and showed substantial average benefits across studies for cognition, language, and parenting practices. So that's, there are also some cases where there were no benefits. And I think, well, that's disappointing. It also is something that allows us to learn a lot in terms of what were the issues that caused the lack of benefit. So, for example, the program was implemented in Madagascar, and the infrastructure there, both in terms of the poverty as well as the terrain, meant that it was a really challenging for the staff to deliver and for the people who were monitoring quality to go. In addition to that, they didn't have the resources to leave the toys with the family. So normally we use low-cost homemade toys in the program. And the idea is that they would be left with the family. And then in between the visits, then they could continue playing and doing the activities with the child. But they just didn't have the resources to do that. And there were no benefits. So what it does make us recognize that there may be situations where the system through which we're trying to deliver the program is just not strong enough to be able to deliver it effectively. So I mean, in Jamaica, we've been able to make this transition, but for a middle income country, the health system, the primary healthcare system in Jamaica is relatively strong. And so, but in many other countries and in lower income countries, the health system is likely struggling to deliver on their basic mandates, and to expect them to be able to take on something like this is maybe not always realistic. Another learning experience was the project done by Prof. Alexandra Brentani in Brazil. And this was the first time the program had been used in Brazil. And her idea was that she would use the health system, that we'd use the health system in Jamaica. And she tried using the similar cadre of community health workers in Brazil to deliver the program. It was a complete failure. They just wouldn't do it. She offered them incentives and things like that. And they just felt they had too much work that they were already doing, and they couldn't take on additional visits. Luckily, she had also done a second arm to the trial, in which she hired a new cadre of worker and trained them to be community development agents. I can't remember exactly what she called them. And in that arm of the trial, there were benefits from the program. So here it really speaks to, making sure that the system you've decided if you're going to integrate with a system, you really need to know that it's suitable. So, I think one of the important things of the program is that the evidence base is constantly growing, and we're learning new things as people in different countries implement the program, which is really helpful for us and really helpful for the global ECD evidence. One of the partnerships I'd particularly like to mention is our partnership with the International Rescue Committee. And it was just a really enjoyable partnership. They were so innovative and inspiring as they sought to find ways to adapt the program in really challenging circumstances. First, for Syrian refugees in Jordan, as when that crisis happened, and then more recently with the Rohingya in Bangladesh and with internally displaced persons in Venezuela. Their work also shows that you can deliver parenting content in many different circumstances, maybe not always at scale, but that the ability to be innovative and adapt the program is really important.
So, the big message I'm getting from listening to you is that scaling up successful pilots is possible, but it is necessary to identify what really makes that program work and preserve these elements when moving from a pilot to a scaled up program. So, my final question then is, in your experience, what are some of the key principles researchers and practitioners should remember when taking an early childhood program to scale?
But probably the most important thing is to really understand the context in which you're implementing. So really get to know what the systems are that reach families, how robust are they, what would be the best way of reaching families in that context. It's not always going to be the same. Um, so, and also then to having, say you've decided on a way to reach families in a system, what is feasible? What really, I mean, because as we spoke about earlier, in some situations you have quite a strong system that you're working with, and in others a much, much weaker system. So what is feasible and what investment is needed in order to deliver an effective program? So I think one of the things that's happened to some extent in global ECD is this attempt to try and say that we can deliver ECD programming at very little cost. And while it's reasonable to try and keep costs to a minimum as much as possible, we have to be careful not to suggest that we can deliver ECD program without investment. I think of very few situations where that would be possible. If you think about it, if you've figured out how to develop, how to implement, you've identified who's going to deliver it. Well, are they existing staff within a system? Are you going to ask them to do additional things? Or, I mean, as is most likely, though doesn't always often happen, some additional staff is necessary. So those kinds of questions are really fundamental. And I think those sorts of things are so important for sustainability that they really need to be thought through very, very carefully. And then obviously as part of this, figuring out together with the government or whoever, if it's an NGO, whoever is going to be delivering the program, how it can be sustainably funded. So moving away from that kind of larger context, you then have to be certain that what you're going to deliver is actually going to be effective. So nowadays, there's a lot of discussion about taking the opportunities of times when people pass through various places, health centers, and so on, and giving them some very brief, what's being called light touch intervention. And I don't think there's not a problem with that. I mean, I think it can have a benefit in perhaps raising awareness of early childhood and so on. But I think we have to be careful not to anticipate that something very light touch is going to actually have benefits, sustainable benefits for children's development. So I think it's very important to make sure that the content is sufficient, that the people delivering have been well trained, and that you have a system in place to monitor the quality and maintain quality. And that often is one of the key areas where things are very, very difficult. I mean, if once you have a program that's had with content that you're going to use, you've adapted it for the context, for the culture, it's appropriate, then, and you've trained the people who are delivering it, all of those things tend to be they're not easy, but they're feasible and manageable. I think where programs at scale often fall down is in identifying how to monitor and maintain quality. Because there's systems often don't have the relevant staff or sufficient staff to do this. And I think it's an area where we do need innovation, and we can use greater use of technology will help to see to make sure that that aspect also gets done. So I think those are, areas that people really need to think about and figure out how they're going to get those things done. But I think we have enough evidence now to suggest that in that there can be it's possible to scale, it's possible to have benefits at scale, but it is difficult. There are lots of challenges along the way, and we have to have a greater understanding of the implementation issues so that we can really think through and maybe try and, to the best of our ability, to resolve those earlier rather than later.
Great, thank you. So sadly, that's all we have time for in this episode. Thank you, Susan, for talking about your experience of scaling up the Reach Up program. There are certainly a lot of learnings for researchers and practitioners trying to achieve similar outcomes. And thank you for listening, and do please join us next time.